and we're housed at Wake Forest University School of Medicine under the direction of Drs. Kimberly Wagner and Mark Wolfson. We serve 8 states in the Southeast, from Kentucky and the Carolinas down to Florida and all the way over to Mississippi. We offer free technical assistance and training to the prevention workforce. We are not alone. There are 10 regions. And so for all of those of you that live in other states and all the way out in Hawaii and even in Puerto Rico and other territories, you have a PTTC there to serve you. You also have an addiction technology transfer center, and you have a mental health technology transfer center. We are all free to you and offer services. You also have the Opioid Response Network. And the Opioid Response Network is actually sponsoring this presentation today. We're really excited to collaborate with them to bring Dr. Shorter to all of you. And I'm going to invite Kenesha to just tell us a little bit about the ORN, the Opioid Response Network.
Good afternoon, everyone. I'm Kenesha Gaston. I am a training and TA specialist for the Opioid Response Network. So what I do is I help implement these trainings from inception to, we kind of deliver them. We kind of walk through the process. I connect with the organization and ask, what exactly are you needing for your training? What's your ask? Who's your audience? And we kind of, we walk it out to make sure that is inclusive for all. So with the Opioid Response Network is we're fairly funded through SAMHSA, and we're funded to provide training and TA to address the opioid and stimulant crisis across the U.S. And as Kristen stated, we're all over. So it's one of me in every region or every state, and all of our trainings are at absolutely no cost to the organization. And if you want to learn more about our trainings that we have and our services that we offer, you're more than welcome to go to the website. And if you actually put in a request, someone will be back with you into about two days, honestly, but we're very responsive with those turnaround with those requests. So if you have any additional questions, I'll be more than welcome to answer those at the end.
Thank you so much, Kenesha, and thanks again for your collaboration on this. All right. So important to note that there is an evaluation that follows this webinar. When you close out, you'll be sent to an external site. That's the evaluation. We really do value your input and feedback, and we also share it with our presenters. So do take a moment to complete that evaluation. We very much appreciate it. And when you're done, don't close it out right away, because the certificate of attendance, which I know is very important to many of you, is going to download, and you can put your own name in it and save it on your desktop. This webinar is being recorded, and it will be on our YouTube channel in a few days. So you could go to YouTube and search Southeast PTTC, and it will come up. All of our webinars are recorded. So if you missed a webinar that you were really interested in hearing about, go to our YouTube page. Down at the bottom of our main website is where you can quickly access the YouTube channel. You can also sign up for our newsletter. It just comes out once a month, and it lets you know about what's coming up in the Southeast, what webinars we're presenting. We sometimes highlight what coalitions are doing in the Southeast region. So if you have a great story to share, reach out to us, because we'd love to give you props in our newsletter. We have a few upcoming events. The first full week of February, we're doing a collaboration with the Central East PTTC and SPTAC on advancing health equity through the SPIF. So check that out, and you'll see a couple other things coming up. But without delay, I'd like to go on and get to the presentation today. I want to tell you just a little bit about Dr. Daryl Shorter. And what I have to share is really short. If you were to read his full bio on our website, you would wonder, how on earth does he even have time to be with us today? Because he is a very busy man. But he's a diplomat at the American Board of Psychiatry and Neurology, and he is board certified in both general and addiction psychiatry. Dr. Shorter is an associate professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He also serves as the medical director of addictions and recovery services at the Menninger Clinic, as well as the program director for the BCM Addiction Psychiatry Fellowship. In addition to his work at Menninger, Dr. Shorter is the psychiatrist of record at the Montrose Center, which is Houston's LGBTQ plus behavioral health and community center, where he supervises addiction psychiatry fellows who provide mental health and substance use disorder treatment services. His monthly column in the Outsmart magazine is widely read and serves many. So with that, Dr. Shorter, I'm going to welcome you and invite you to share your slides. Thank you for being here today.
Thank you so much for having me. I'm so excited to speak with everyone today about this topic, and I will share my slides and make sure you all can see me. Thumbs up. Great. Thank you so much. So when we were talking about the creation of this talk and what we might like to thank you, Ben. I appreciate you, purple suit. When we were talking about the creation of this talk and what prevention can look like as it relates to stimulant use in our communities, our initial discussions really focused on understanding the who, what, and why of psychostimulant use and how that has changed and evolved over the last several years. Sadly, I was reading in the news this morning about the passage of a celebrity's son from an unfortunate fatal overdose, and the person passed away, and they announced what was in his system at the time of his demise, and included among the substances was cocaine and also fentanyl and ketamine. And although I won't be speaking very much about opioids or other types of substances today, I was thinking to myself, and when I was thinking about this talk, that we really are kind of in the midst of a really polysubstance overdose epidemic. I know we have spent a lot of time talking about the opioid epidemic and the opioid overdose epidemic, and certainly that is true, that is the case. But I do think it's important to acknowledge that for so many people, that stimulants play a huge part of their overall use pattern and their use trajectory, and can also contribute significantly to the morbidity and mortality of folks in our country and beyond. And so with that, I want to make sure we get started, but just to acknowledge that stimulants are a major source of concern, one that we should all be thinking about in addition to the ongoing conversation about opioids. With that, I have no financial conflicts of interest to disclose. Today, I'm going to spend a little bit of time talking about the types of psychostimulants, as well as common routes of use and the epidemiology of stimulant users. In addition to that, we'll spend the majority of our time today talking about the intersection of social determinants of mental health with stimulant use, and how that might lend to the creation of health disparities among vulnerable populations. And then finally, we'll talk about some outreach strategies that you all might be able to use in engaging communities around prevention efforts among stimulant users. So to level set, what is a psychostimulant? So it turns out that there are a couple of different ways that we define substances that people might use either recreationally or have as a part of a substance use disorder. Sometimes we define those substances based on the effect that they have. Other times we might define them based upon the receptors that they hit. So for example, we talk about cannabinoids because they impact the cannabinoid system. Psychostimulants, we have named them that because of the action that they take. And psychostimulants broadly are substances that activate the reward and reinforcement pathway, mediated primarily through activation of dopamine neurons. And they have a number of effects that people look for when they are using them. So in addition to causing mood elevation or euphoria, people feel more alert, they have decreased need for sleep. Of course, people use them to have better focus or better attention. Some people use them in an effort to suppress their appetite. They can also increase one's self-confidence. They can increase one's libido and also can prolong orgasm, which may explain why stimulants are such a large part of the chemical sex or chemsex community. And we'll talk a little bit about that as we move forward. The types of psychostimulants that exist, caffeine, which is probably one of my favorite stimulants. And I certainly load up on caffeine every morning before I come into the office. And perhaps some of you all are engaging in stimulant use right now as you are watching me and having your lunch. Of course, there are prescription medications. We'll talk a little bit about non-medical use of prescription stimulants over the course of the next hour. But these are medications that are FDA approved to treat conditions such as ADHD, narcolepsy, and of course, also because of that appetite suppression that people can experience as a result of psychostimulants, overweight, or obesity. We'll spend a little bit more time today talking about substances, including cocaine and methamphetamine, but I also wanted to acknowledge that MDMA, or sometimes kind of commonly known as Molly or ecstasy when used in recreational settings, is also in some categorizations considered a psychostimulant. Now, one thing to note about MDMA is that I really think it is important for us as folks that work in the addictions field to really begin breaking MDMA out from some of these other substances like cocaine and methamphetamine. Now, of course, it's important to acknowledge that both cocaine and methamphetamine, as well as amphetamine, are FDA indicated for the treatment of certain conditions. So, for example, cocaine might be used in eye surgery, for example. Methamphetamine, there's a prescription formulation of methamphetamine that's FDA approved for ADHD. But MDMA is currently being studied for treatment of things like PTSD and in the context of MDMA-assisted psychotherapy. And so the way we discuss MDMA with our communities, with other prevention specialists, I think it's important for us to acknowledge that there is not only this sort of recreational aspect of it, which you might think about related to Molly or ecstasy, but also the treatment aspect of it when it comes to psychotherapy and psychotherapeutic treatment of PTSD. So there are a number of routes of psychostimulant use that we can talk about. So oral, of course, someone ingesting it, and that's not just with the oral medications or the non-medical use of psychostimulants. You might also find that people use things like methamphetamine in an oral fashion. I have had clients that I've worked with, patients that I've worked with who have ingested methamphetamine orally by wrapping it in a little bit of Kleenex or toilet paper and ingesting it in that way. And so one of the things that I'm hoping that you'll be able to talk to your audiences and your communities about is how these routes of psychostimulant use can really range kind of quite widely for people. And so it's important in our assessment of patients, our assessment of clients, and in our discussion with communities to begin asking and really be consistent with asking, well, how are you using this psychostimulant? So intranasal use, you can see that with basically all of the psychostimulants that I'll be talking about today. So including prescription as well as cocaine and methamphetamine. People also smoke prescription stimulants as well. So you might find that in some communities, people are more likely to crush and smoke psychostimulants that are like Adderall, Ritalin, and those types of medications. Intravenous use is another route by which people use psychostimulants of all kinds. And then I wanted to make sure that we also mention the rectal use of psychostimulants, which we might see happen commonly with gay, bisexual, and men who have sex with men, or GBMSM, who might use psychostimulants like methamphetamine in a rectal fashion as part of a chemsex session. When it comes to the epidemiology of stimulant users, this is data that's taken directly from the National Survey on Drug Use and Health, our most recent data from SAMHSA. And over 10 million people aged 12 or older reported past year misuse of a psychostimulant. So if anybody asks you how many folks in the country are perhaps engaging in misuse, this is the best estimate in our most recent data. It's about 10 million people. Now, the majority of those folks are users of cocaine, with over half of those folks being a cocaine user. You've got about 4 million, a little over 4 million people who have misused a prescription stimulant in the past year, and almost 3 million people have misused methamphetamine or used methamphetamine in the last year. But the thing that I think is kind of interesting and important to note is that when you do the percentages, about anywhere from 60 to 70% of those users use only that one substance. So about 70% of the folks are only cocaine, 70% are only stimulant misusers, prescription stimulant misusers, and about 63, a little over 60% are meth use only. That means that there's about 30 to 40% of folks who engage in use of more than one type of psychostimulant. And in fact, there's a couple 100,000 people that use all three. So when we begin thinking about our work, ask yourself, how does my work take into consideration those folks who use multiple types of stimulants, where their use pattern is not just about cocaine? Because I think sometimes we can get narrowly focused and focus only on the meth use, or focus only on the psychostimulant use, or focus only on the cocaine use. But really, are we assessing people for multi-stimulant use? Are we prioritizing that as an approach when it comes to prevention? Are we talking to people about the combination of these substances and what that might lend itself to in terms of psychiatric sequelae or medical complications? And so that's something for you to wrestle with, and maybe we can talk about that as we move forward. And we leave some time for questions and answers toward the end. And I want to make sure that we spend the majority of time talking about the why of psychostimulant use today. But I do think it's important for us to at least acknowledge that stimulant use can look different among minoritized communities. So if we look at, this is again data from the most recent SAMHSA National Survey on Drug Use and Health. If we look at racialized categories, so American Indian and Alaskan Natives, I think it's interesting to note that they are the only community where stimulant use, psychostimulant use, the non-medical use of stimulants such as Adderall, Ritalin, methylphenidate, etc., where that use is third, okay? And that's in counter-distinction to Black African Americans, where cocaine remains the #1 psychostimulant that is used in that particular community. We will do a breakout during this talk and focus on the intersection of Black gay men, where there has been an increase in methamphetamine use in that specific subset of folks. But overall, generally, Black African Americans are still, their #1 stimulant, according to this data, is cocaine. I think it's important to also acknowledge that people who identify as multiracial, about 22% of the people in that category had a past year substance use disorder. That's second only to American Indian and Alaska Native folks. But what you find is that among multiracial folks, that the first, second, and third most common stimulants track along with Asian, Hispanic, and Latinx folks as well. Among women, about 15% of women had a past year substance use disorder. And among women, the most commonly used stimulant is non-medical use of psychostimulants. And then when we look at LGB individuals, what you find is that cocaine may be the third most common, but that methamphetamine is certainly #1. Alarmingly, almost 37% of LGB individuals met criteria for a past year substance use disorder. It is important to note that I'm not purposely trying to omit Native Hawaiian or other Pacific Islanders. It's unfortunate that the SAMHSA National Survey on Drug Use and Health simply does not include this specified data due to low precision. Okay, so we've talked about the types of psychostimulants. We've reviewed some of the common routes of use and, in fact, some of the different communities and how they may use psychostimulants, and we've spent a little bit of time talking about epidemiology. Let's dive now into the social determinants of mental health and how that impacts psychostimulant use. I think it's important to begin with a little bit of a history lesson, however, because this context isn't just about what we have recently become familiar with as in terms of social and structural determinants of health. There's a history, and this history is known, even if it's not necessarily sort of consciously known or people know the details of it, it is known and widely understood within communities. So this is an article from the New York Times, 1914, so over 100 years old. And if you can read it, it says Negro cocaine fiends are a new Southern menace. Murder and insanity increasing among lower class blacks because they have taken to sniffing since deprived of whiskey by prohibition. So what we understand about the relationship, political and social relationship of our country to substances is that there has been a long-standing racialization of substance use. Certain racialized groups were associated with certain substances. And the association of Black African Americans with cocaine isn't necessarily new. It's something that has been with us for well over 100 years. It's also important to note that how a particular city or a particular state thinks about that relationship can have a direct impact upon the legislation that gets passed, upon the financial and economic decisions that are made within particular communities. And so there is a context, a historical, socio-cultural context that is really quite important. So that by 1914, 46 states, and at that time there were only 48 states in the Union, 46 states had regulations on cocaine, and an additional 29 states had laws prohibiting opium, morphine, and heroin. And perhaps during the Q&A, we can talk a little bit about the racial group that was most associated with opium use at that time in our country's history. So I'm going to fast forward. This is a much, much longer and detailed conversation, but I want to fast forward from the 1910s through the 1970s and into the 1980s when we arrive within the presidency of Ronald Reagan. And now the term the war on drugs had been coined by Nixon years prior, but it was really during the Reagan era that we saw this increase in legislation and really the ways in which money was used to support what was known at that time the drug control budget. So interestingly enough, when Nixon sort of coined the phrase the war on drugs and began that work, really his idea at that time was to spend the money from the federal government. About 50% of it was devoted to enforcement, to law enforcement related to drugs. But the other 50% was really related to treatment. It's around the time of Reagan that we begin to see this shift where money from the federal government shifts so that, yes, there's money available for treatment, but more and more and more, you're seeing that money go toward enforcement. And that's enforcement both within the context of our borders and at our borders, a process called interdiction, where you're preventing substances from coming into our country from outside, things like cocaine, for example. And perhaps one of the troubling and problematic things that came out of this time is the Anti-Drug Abuse Act of 1986 for a lot of different reasons. But the reason that you may have heard of or be familiar with this is because it established what's called mandatory minimums. So a mandatory minimum is the mandatory amount of time in prison that someone would get if they broke a certain law or were convicted of a particular crime. And the mandatory minimums around cocaine possession at that time in 1986 were around crack cocaine and powder cocaine. But what was found at that time was that, or what was passed at that time was, if someone was in possession of 5 grams of crack or 500 grams of powder cocaine, that they would get an automatic 5-year sentence. Now, there's a pretty big difference between 5 and 500, but somehow the dangers associated with crack were so inflated that it was thought that even just being in possession of 1/100th of the amount of powder cocaine, that required an equivalent sentence to what you saw with powder cocaine. It is also important to note that back at the time in 1986, roughly 80% of crack cocaine users were Black. Now, the other piece of this that it's important to acknowledge is if you look at the budget and the way that money was being spent back in 1986, almost $2 billion were a part of our drug control budget at that time. Take a look at what was spent on treatment and education, roughly 26%. So again, I want you to be thinking about like what messaging is present in certain communities about their relationship to substance, and do they need treatment or should enforcement be utilized? Because these are the communities that you're going to be going into. These are the folks that you're going to be talking to with prevention efforts. And even though, again, they may not know that it was 26%, there's like a cultural community awareness and a community knowledge and understanding that treatment and education was not a big part of this for most people. States, great question. So the question is about, what does states mean? States got money directly from the federal government so that they could then determine how exactly they wanted to use that money within their state to address the scourge of drug use. So that could have meant education efforts, it could have meant prevention efforts, it could have been them funding treatment within their specific settings, it could be about research or tracking, that sort of things. How, we don't know exactly, we would have to look and dig down specifically. I don't want to make any assumptions, but we would have to look and dig it to see exactly how each state chose to use that money, but the states overall received a significant portion so that they could then determine how they wanted to use that money with their particular community. I'm going to fast forward a little bit. I promise I won't give you too much of a history lesson, but I think it's important to understand this context. To the George H.W. Bush presidency. He was president from 1989 to 1993. And the thing to keep in mind or to know about the Bush presidency is that Bush 1 spent more money on the drug control budget than the 3 previous administrations put together. There was a substantial uptick in his use of federal funding to push for enforcement rather than treatment. And so when Black and brown communities talk about policing and over-policing, there's a context for that. And it didn't just begin 10 years or 20 years ago. This has been something that's been present for a number of years and can in some ways be traced back to the increased enforcement and the use of military-grade equipment for anti-drug operations by local and state police. That happened under Bush 1. Okay, fast forwarding to the Clinton era. There was further militarization, and you all may recall lots of discussion about the crime bill of 1994, which again increased prisons, increased police. And in 1995, I think it's important to acknowledge that Clinton and Congress overrode the U.S. Sentencing Commission's recommendation to eradicate those racial disparities in cocaine sentencing. So the very racial disparities that were noted as a result of the mandatory minimums from the Anti-Drug Abuse Act of 1986, it was less than 10 years later that they tried for the first time to remove those. However, that was being seen as soft on crime, soft on drugs, and it was defeated. And then finally, just one other word. I think it's important to sort of zoom out and say, okay, well, what does it mean if the director of the Office of National Drug Control Policy is also an Army general? What does that indicate about our country and how we think about substances, substance use disorder? I mean, that terminology of the war is really important for us to begin understanding. It means that it's much less treatment focused, that we have to enforce and arrest and prison our ways out of addiction. The other piece of this that I think is important to acknowledge is that it was really out of this time that we began seeing kind of an increase in foreign aid to other countries so that we could help them to fight their war on drugs as well. Between 1980 and 1997, the number of people that were incarcerated for non-violent drug-related crimes rose from 50,000 to 400,000. So we should not imagine, we don't have to imagine incarceration rates going up. Like, we actually have the data to support this understanding among certain communities. This is true. that we saw communities decimated, families destroyed as a result of the war on drug users. Okay, so that's the context. So cocaine use among African Americans has been linked to all kinds of things in the media and in the law for well over 100 years. Go back to your New York Times article. The over-policing of Black and brown neighborhoods, again, context, harsh penalties, and ultimately failed war on drug users led to extensive community disruption and mass incarceration. And while use of cocaine use among African Americans appears to have declined over the past several years, use of methamphetamine has been on the rise. Now, cocaine use is still number one, but meth use has gone up, especially among certain members of the Black African American community. Now, the question we have to ask ourselves is, what does this mean about members of this community and their likelihood or their willingness to come in and discuss certain aspects of mental health, certain aspects of substance use with treatment providers? How much trust do you think is present when this has been the history in our country? So I want to root this, and this is a really wonderful model that I came across, but I think it really helps us to understand the place of social determinants of mental health and how that can ultimately increase risk for members of vulnerable communities in engaging in substance use and developing substance use disorder. So we spent a little bit of time talking about racism, and I've been doing some reading. There's a wonderful book that talks about the American racial system as a caste, and so I've been really kind of thinking about caste as one way of understanding race and racism in our country. But racism and structural racism, how being baked into our legal system, being baked into our education system, certainly is a factor and can explain why it is that people may be more like from certain racialized minoritized groups might be more likely to engage with a substance and develop a substance use disorder. Of course, there's sex and gender discrimination, as well as homophobia and transphobia, all of these invisible forces that kind of wrap around people and really permeate into their lives in these ways that it can sometimes just be inexplicable. Important for us to acknowledge the presence of those. Of course, there's bias, both explicit and implicit. I love starting these sorts of talks and talking about our use of language. Language is really directly reflective of the biases that we sometimes carry. And so it's really important for us to try to use person-centered, person-first language to really try to get away from stigmatizing people in that way. And we think about that because of its relationship to bias. Healthcare education and healthcare literacy is a huge part of this. We know and understand that people who have more knowledge and more understanding of their bodies and their relationship of their bodies to their social environment and what they eat and what they drink and how they live and what they smoke and all, or don't smoke, that is important, and that has real life consequences for the development of, exposure to, and progression of certain medical conditions or other types of diseases. Certainly lower social economic status, lower income, food insufficiency absolutely have an impact on one's mental health. Breaking away from some of those systemic challenges, I think it's important for us to acknowledge that the neighborhood in which one lives can determine so much about mental health. Of course, if someone is struggling with housing instability, or if they are unhoused, having adequate transportation to and from, or being in proximity to medical care, huge. Exposures, toxic exposures, whether or not it's lead or the quality of water. I can't believe sometimes we're still talking about Flint, Michigan. There's a big thing in Jackson, Mississippi. I mean, so toxic exposures is still very much present for us in today's society here in our country. And of course, exposure to safety and violence. If you're not feeling safe in your community, if you're exposed to violence, absolutely that's going to have an impact on your mental health. And then you finally get down to the person and what their experiences are like in the home, their experiences are like in the school, and their experiences, what they're like experiencing within their communities. So we know about adverse childhood experiences at ACEs. Of course, if people have negative life events, experiences of trauma. Seems like at least we've caught up with I think, an understanding that we need to be talking about trauma with people, asking people about trauma, and then making sure that they get referred to the appropriate resources. Even though we are more connected than ever, and I've been looking at my phone the entire time because I'm tracking my time, even though we're constantly on our phones, engaging with people on social media, the number of people that I talk to on a regular basis as a psychiatrist who still feel isolated, still feel terribly alone, and who really actually may feel more alone because they are lacking kind of an emotional closeness, friendship, intimacy, despite the fact that they're communicating with people on social media, seems to have gone up. There's a significant mistrust of systems and providers. And I think that mistrust of systems has been present in certain communities for quite some time and really is rooted in the things like we're talking about, like a 1914 article in the New York Times. And then, of course, people's lived experiences with discrimination as a result of the structural racism, sexism, homophobia, transphobia, et cetera, that they might experience. So you take all of that together as the social and structural determinants of mental health, and then you combine that with the genes, the genetics, the biology that somebody comes to the planet with, their family history, what their brains like, the genes, et cetera, et cetera. And you take all that together and you have these interactions between genes and environment, and those things together can really explain in some ways why it is that there are certain groups that might be more susceptible to or vulnerable to the development of substance use disorder, and also explain why it is that they may be more likely to have negative outcomes as a result of engaging in substance use. So I want to talk now specifically about LGBTQ folks. Now, the interesting thing is that even though there has been increasing social acceptance of LGBTQ folks, sometimes referred to them as queer folks, over the last several decades, we've seen this, we've witnessed it, marriage equality, yay. At the same time, you'll see on the y-axis age and the number of years, the average age of coming out has gone down significantly. Back in the late 70s, early 80s, people were coming out around 20 years old. Now, most recently, it looks like people are coming out around age 12 or 13. And in fact, some studies suggest that 1 in 6 Gen Z adults identify as queer. So, okay, great. People coming out more, people feel more comfortable. Everything's got to be gravy now, right? Well, I think it's important to at least acknowledge that we have seen over the last 2 years doubling of the number of anti-LGBTQ laws that have been, bills that have been introduced in states across our country. The ACLU estimates that last year we had over 500 bills introduced in state legislatures, with 84 of those bills ultimately being enacted. It's twice what we saw in 2021. Okay, so when we talk about the context for Black folks, now we're talking about the context for queer folks. This is a spattering of the legislation that we have seen introduced, not necessarily passed, in 2023. The vast majority of these laws have focused on restricting student and educator rights, and they include things like curriculum restriction. You may recall the Don't Say Gay bill, this idea that we're not allowed to teach certain things, or we're not allowed to teach certain things to kids of a certain age. So if you're between kindergarten and 3rd grade, you can't talk about queerness at all. Now, what do you do if you have 2 dads or 2 moms, or 3 dads and 3 moms? You obviously can't even bring, as a kid, can't bring yourself and your family to school because you're not really allowed to say it or talk about it. There's now this concept of forced outing in schools as well. So if a kid shows up to school and they present gender in a way that is different from what might be expected from what they were assigned at birth, students, counselors, et cetera, are required to then pass that information along to parents or guardians. Of course, there are a number of school sports bans as well. There were almost 200 healthcare restrictions that were introduced. I think you all may recall I'm in Texas, and so this one is the one that got my attention and the attention of my colleagues here. Back in June of 2023, we saw the passage of Texas Senate Bill SB 14, and that prohibits state licensed physicians from performing procedures or providing gender affirming care for children younger than 18 years old. And just to be petty, creating barriers to people finding accurate IDs. There are 20 of those sorts of bills that were passed, as well as a number of drag bans. The one that you may have heard the most about was in Tennessee, but this was ultimately withdrawn, like within the last week, where they rewrote the definition of what it means to have adult cabaret entertainment and argued that it was harmful to minors to see drag performance. Not just about the legislation, though. We have also seen, and this was data from the FBI annual crime report, that there's been an increase in the number of hate crimes reported based on both sexual orientation. You saw a 14% increase in those types of crimes and 33% increase in the reported hate crimes based on gender identity. More than 1 in 5 of any type of hate crime in this country is motivated by anti-queer bias. So, on the one hand, we are seeing greater visibility and acceptance, and I think that most people would argue that that is true. And at the same time, we have seen increasing attacks through legislation and anti-LGBTQ violence. And we also see persistent negative health and psychosocial outcomes. So this is the context for your queer communities when you are engaging them in conversations about prevention. The other piece of this that I want to make sure we talk about is queer identity formation, like how queer identity is formed within the context of this American society. So there's the concept of heteronormativity, this understanding that it is normal to be heterosexual, to identify as heterosexual. So if I were to say to you, a man marries a blank, and under the rubric of heteronormativity, you say, okay, a man marries a woman, like is represented in this graphic. But then if I were to go on and say like, okay, man and woman, they get together, they get married. First of all, heteronormativity assumes marriage. And then they have kids. If I was, how many kids are they supposed to have? I think everybody knows 2.2 or 2.5. We all kind of got that knowledge. I'm not even really sure where we got it from, but we all have received that message. Then, okay, after you have your 2.2 kids, you can't live in the city anymore, so you have to move to the blank suburbs. And then you build a house. People, assuming everybody in heteronormativity lives in a house. And it's surrounded by what? A white picket fence. So heteronormativity helps us to understand that there are certain norms, mores, social values that we should carry, and they have to be consistent with heterosexuality. So then anything that deviates from that, the nuclear family, is deemed other, deviant, wrong, sinful, immoral. We've got blatant homophobia, which we've talked a little bit about, as well as transphobia. I didn't talk about bathroom bills, but bathroom bills are another part of anti-LGBTQ legislation that has been introduced within the last year. You've got the concept of toxic masculinity. There's a right way and a wrong way to be a man. There's a way that you're supposed to present or a way that you're not supposed to present. I would argue that there's probably also toxic femininity as well. I think there's a certain family that I won't talk about, but they have done quite a bit to help young girls and women understand, like, you're supposed to have a certain bust size, a certain butt size. I mean, there's a reason that I think we're seeing so many people getting surgical alteration in an effort to look a certain way, toxic femininity. And then there's also perhaps homonormativity. And I think it's important for us to acknowledge homonormativity because of its impact on people who identify as bisexual and contributes to like biphobia, bi erasure, bi invisibility. Because you're either straight or you're gay. We don't allow people to have that type of fluidity or even identity as a bisexual individual, erasure. Take all that together, for Black folks, for brown folks, for queer folks, for women, and what you get is this concept of minority stress. And I really think if we understand minority stress as being the core or the seed, it then it's possible for us to then understand why substance use, engaging in substance use, initiating substance use, or going on to develop substance use disorder is perhaps more likely to certain vulnerable communities, particularly in conjunction with the biological genetic piece that I discussed. I mentioned to you that I would talk about the intersectionality piece. So you also have queer people of color who are not only dealing with perhaps homophobia, transphobia, but also dealing with racism. And one would hope that within your own group that you find a sense of acceptance. However, queer people of color might experience ostracism from other members of their racial or ethnic group. I'm going to go a little bit further and talk about religion as well. That might also be ostracism as a result of religious or cultural background. But then coming into the queer community, experiencing racism and racial bias, both implicit and explicit, both in dating and not in dating, that can also be a major factor for people. So as a result, queer POCs might feel like they don't really belong anywhere and really can experience a loyalty bind and conflict related to like, where do I belong? It's from within that context that I think it becomes really important for us to talk about Black gay men. So African Americans, generally speaking, when it comes to methamphetamine, are older at the time of their first use. That they typically use smaller amounts, fewer grams used in the past 30 days, larger percentage reporting anonymous sex in the last 2 months, but lower levels of social stigma and negative self-esteem from methamphetamine use, and they're less likely to engage in IV use of meth. But when we think about meth use among Black gay men, it's important to kind of acknowledge that at least historically, the bar and club scene has been a major part of where queer communities have found safety, communion, acceptance, recreation, a number of different things. And so the centrality of this club bar scene has, I think, impacted our understanding and made us think that this is the only way that people can develop community, which obviously isn't necessarily true. But there is, as a result of this, a linkage with substance use and sex. So many Black gay men actually perceive that their racial and ethnic community has a strong dislike of hard drugs like methamphetamine, so that even engaging in meth use makes them more foreign, even more foreign in their racial community. And this is sort of epitomized by its association with white gay men. It's a white drug. It's a white gay man's drug. So that Black gay men who may engage in that use feel even more stigmatized and biased as a result of that association. So when Black gay men might engage in methamphetamine use, it's not always because they were introduced by other Black gay men. It seems that the most common pathways through white gay men, either as a sex partner or as a significant other. There can also be the introduction by platonic gay friends or in these non-sexual gay social settings like bars, again, because of that kind of association of queer culture with the bar scene. But I just want you to think about, like, where is it that people are most likely to encounter these for the first time when it comes to initiating methamphetamine use, and the complexity of like how you no longer belong. You're sort of between at baseline, creating all this loyalty conflict and this loyalty bind, but then the drug use further compounds that experience for members of this community. So, points to ponder. One, how do your prevention efforts take into consideration the totality of a person's experience and their multiple identities? How can you complicate and add nuance to your prevention work so that you really are taking into consideration not just one or two pieces of demographic information, but also things like their marital status or their parental status, their educational background, their language, and not just language, even if the person has an accent, and what that means for the way that they move through the world and how people might respond to them or judge them. Geographically, where are people located? And we talk so much about like North and South. We talk so much about city and rural, but even within our cities, there are areas locally that are in your local community where the experience of those people is very different from other people in the same city. Can you complicate your understanding of geography in that way? What about the way that his parents, the way that they move through the world? Their religion, location, nationality, all of these things can be major factors. And I'd be remiss if I didn't also add in, if a person is living with a disability or medical condition, that also can be heaped on and become a major, like almost central part of their core identity. Okay. I haven't talked about it just yet, but I want to make sure we spend a little bit of time talking about the non-medical use of prescription stimulants. And it's a great time to talk about students. So it turns out we have seen an increase in the number of emergency department visits, although there have been no real changes in the number of clinical visits that involve prescription stimulants. It appears that the group of folks that are most at risk for non-medical use of prescription stimulants are those aged 18 to 25 and college students. College students report that about 2/3 of them have been offered a prescription stimulant for non-medical use. 2/3. It's a lot, 2 out of 3. And 30%, over 30% report non-medical use of psychostimulants. Now, when you ask them, okay, well, why are you using? The majority of them will tell you, oh, I use it to enhance my academic performance, to study longer, to study harder, to stay awake, et cetera, et cetera. But that doesn't really tell the entire story, because the association of non-medical use of prescription stimulants with other substance use and or heavy drinking is quite high. So there was a study that came out recently that took data from the American Community Survey, which was run in 2016, and among students that were reporting non-medical use of prescription stimulants, over 40% reported a lifetime diagnosis of ADHD, 90% reported polysubstance use, with 55% of that group using substances other than cannabis. Okay, so automatically, I think it becomes important with prevention efforts that we take into consideration that even someone is coming in saying, oh, I only take Adderall to study. Don't know that that is entirely the case. At least this survey does not indicate that to be true. Does it become important for us to ask, in what order are you using these substances? 43% use an illicit drug prior to prescription stimulant non-medical use. 1/4 of those folks use both at the same time. And about 1/3 engage in prescription stimulant non-medical use prior to the illicit drug use. Okay, what does that mean? It means that we need to talk to students and have real honest, candid conversations with them about the way that they combine substances. So prevention efforts might focus on not just, okay, don't engage in this, right? And we'll talk a little bit about that in a second. It also might be, all right, well, let's talk about, like, if you're using these substances, like what does combining them look like? How do you go about doing that? And can there be some safety and safeguards put in place around that type of use? Now, most people that were using stimulants, prescription stimulants, used oral or in an oral fashion. But non-oral use was also present, largely by snorting. So again, that route of administration becomes pretty important. We've also seen that there's been increased non-medical use of stimulants among Black African Americans, and that has been, again, associated with a rise in MDMA use, as well as other types of substances. So other substances that may be in play include benzodiazepines, which are used to treat the come down from MDMA or ecstasy. Opioids, people are introducing opioids in the context of MDMA use as well as psychostimulant use to give a different quality of high. And then the stimulants are used in conjunction with MDMA to add energy to the overall drug experience. Among those who are using non-medically, Hispanic, Latinx folks have higher frequency of use in comparison with whites, but not necessarily higher rates of stimulant use disorder. And if major depression is involved, that increases the odds that the person might engage in opioid use and stimulant use, although there may be some protective factors related to religiosity and spirituality. When we look at where college students are obtaining these prescription stimulants, number one source is they get it from one or more doctors. And number two is they either purchase from a dealer or a stranger. And again, when you ask about like sort of risk factors or the why of psychostimulant non-medical use, there are certain things that come out. Males, age 18 to 25, which we talked about, identifying as white or other, again, that multiracial categorization that I mentioned earlier, being a member of a fraternity or a sorority, and if someone is involved in other types of substance use, including alcohol, cannabis, or other stimulants. And when asked, why do you engage in this use? To study better, to stay awake, to lose weight. Okay. So I threw a lot at you just now, but in our remaining time, and then I want to make sure we have a little bit of time for questions and for comments from the audience. There are innumerable prevention efforts and articles out there. So this is really intended to just be the tip of the iceberg in this part of the conversation. And I want to invite people to share what it is that you are doing, what you found to be helpful or maybe not even helpful as part of our dialogue at the end. So we're going to talk outreach strategies, tip of the iceberg. Okay. The first question that I think you have to ask yourself is, what are you trying to prevent? It's important to know where you're headed, where you're going. And some of my more ambitious audience members will say, all of them, and I hear you, I'm with you. But as you are trying to prevent all of these things, maybe breaking these down into perhaps a bit more digestible units could be helpful. So, for example, drug initiation. If you're trying to stop or prevent, the initiation of substance use or the initiation of psychostimulant use, ask yourself, okay, well, among whom? I'm trying to stop this among elementary school, grade school age kids, high school age kids, college students, which we'll talk about in a second, or young adults, veterans, people who graduated from high school but then go immediately into the workforce. Among whom are you trying to target this treatment? I think that becomes pretty important. Now, say the person already has established a substance use disorder. Are you trying to prevent the recurrence of use or reduce the risk? Separate talk altogether is harm reduction. So we won't be talking about that per se. But perhaps you're trying to prevent recurrence. Overdose both non-fatal and fatal. We'll talk a little bit about overamping. Sexually transmitted infections, thinking about sexually transmitted infection as a way by which to also address on the side, but include a conversation about the relationship to substances. That might be very different from bloodborne infections from sharing drug use equipment. We are in the midst of, in certain areas of our country, lots of conversation about the combination of fentanyl and xylazine and the wounds that people experience as a result of of combining those substances for intravenous use. So perhaps your work isn't necessarily about even preventing the substance use. It's about preventing medical complications from it. Again, that's a much more harm reduction focused strategy. Psychiatric comorbidity might be what you're targeting. And so perhaps what you're thinking about is trying to help people to use in a way that is controlled enough so that they don't end up overamping, using so much methamphetamine that they end up becoming psychotic, becoming agitated, experiencing significant anxiety, and presenting to our emergency departments as a result of that overuse or overamping. There might also be an aspect of this where we talk to people about the mood disorder consequences that people can experience as a result of engaging in this use and how to prevent those. Of course, psychiatric mortality separate from overdose, but not entirely, because sometimes when people experience overdose, they may be doing so in the context of suicidal ideation or plan or intent. And then finally, as a result of diversion programs, drug courts, veterans courts, perhaps what you're trying to prevent are the consequences of substance use from a carceral or criminal justice standpoint. So the first question you got to ask yourself is, what exactly am I trying to prevent? Who am I trying to target here? Okay, so there are some specific psychostimulant, stimulant-related prevention efforts that have already been written about, published, that take into consideration the social determinants that I mentioned before. So one way of going about this is to increase recovery capital. You may do that, which really is a way of kind of enhancing motivation, providing skills and support for people to be motivated to engage with recovery, however they define it. And you may do so by combating some of those social determinants that I mentioned. Talked about low socioeconomic status. We talked about housing insecurity, being unhoused. We talked about food insecurity. What does it look like to include in prevention efforts a component that focuses on education? Maybe it's GED. Teaching people a trade or a skill that they can use for employment or to start their own business, or providing other types of employment opportunities. Now, employment opportunities isn't just about doing somebody's resume, although that's not unimportant for the record. It might also be about, we've seen some of these treatment programs that have incorporated things like helping people get haircuts, helping people to find clothes that they can wear to a particular job interview, perhaps helping people to fill out job applications. So it really does require kind of a much more holistic approach, and that, especially if you're targeting prevention among folks that have already been diagnosed with a substance use disorder, perhaps experienced criminal or carceral consequences from their substance use. These are preventive and can help reduce recidivism and the risk of recurrence. And for certain members of certain communities, engaging the religious community, engaging them in spiritual practice can be huge for increasing their recovery capital and their sense of connection to this broader a motivation that might help them to remain in recovery as they define it. It's also important to think about, how can we include in these activities support from non-drug using family and friends in an effort to create community and to enhance the overall quality of social networks. It's important to, when possible, and maybe that's what the grant is about, maybe that's what the education is about, maybe it's about trying to let people know that, well, these are the housing and food access resources that are available in your local community, so that we can take another thing off your plate that you won't have to worry about as you try to navigate and not go back to use or continue use in the same fashion. Health education. As I mentioned before, pairing substance use disorder, and really in particular in this case, psychostimulant use education, with education about other medical illnesses and medical conditions, should be a part of kind of what we all do. Now, what's challenging about this, practically speaking, is that oftentimes people might go to their local drug addiction treatment facility. Okay, so this is when you're in that world, in that realm. And what can happen is the individual gets there, and those folks say, I do drug addiction work. They don't necessarily have a provider available to do HIV testing or Hep C testing, or they may not have a provider in-house that can provide medical education or medical evaluation. And so the silos create these barriers for people in terms of navigating. So in prevention, on the prevention side of things, how can we give people as much information as we possibly can about the wide array of services that are available to them, and also give them education about their relationship to a particular substance? it kind of should go without saying, but to the extent that we can embed these types of educational projects and educational interventions in the community, the better. And when possible, involving peers can be extremely powerful. Gender-specific groups are really, really helpful, providing groups that are LGBTQ focused, gay, bisexual, trans, gender diverse. That can also be extremely helpful for people feeling comfortable with asking questions and providing feedback and getting information. Offering food or other incentives to increase attendance can be another major way of engaging folks with your prevention efforts, and really trying to make it fun so that it doesn't have to be just so doom and gloom all the time. Again, involving healthcare workers, but really thinking about how can we leverage peer and community involvement. For example, in the cases of with people living with HIV, can offer or convey a message of hope and talk about their experience of being on medication, adjusting to it fine, not experiencing side effects, and having an undetectable viral load. Also, you want to be careful to avoid shaming and stigma, especially around, this is actually based on an article from 1998. No shame or stigma around trading sex for drugs, IV drug use, unprotected sex, bisexual identity, or having multiple partners. And then finally, using culturally specific language. And I think it's okay to repeat information for people. It's all right for people to hear a particular point over and over again until it gets from here to here. And then also helping people to craft their own risk reduction plans that reflect their own ideas and values. When it comes to focused interventions for non-medical use of psychostimulants, I think it's important to kind of split that. So on the one hand, you might be trying to focus your intervention on college students. And the sooner or the earlier you can do that, the better. So start as soon as they hit the campus. And standardizing these sorts of offerings on college campuses is could be a huge part of the prevention process. Now, do I think that we should wait until college to give this message to adolescents and young adults? No, I do not. I think that including this message at the high school level, or perhaps even younger, is also pretty important. Just so happens that this particular study came from a college student-focused intervention. But just because it was done in college students doesn't mean that we should limit the conversation about non-medical use of psychostimulants to college students. And the probably most important aspect of this whole entire thing is that we begin to challenge the positive expectancies of using a stimulant. So for example, a kid might think, hey, if I take this blank, it's going to make me study better, I'll be able to pass the test, et cetera, et cetera. And that might be true, but it also may not be true. So we really want to kind of chip away at this idea that engaging in that type of use is not harmful, that it's only associated with positive consequences, and the buildup around them. It also turns out that perhaps teaching time management skills, thinking along the lines of like CBT skills for ADHD, that might also be helpful, although it's not entirely proven in the literature just yet. When possible, use peers to support abstinence and to also talk about perhaps negative consequences they may have experienced as a result of engaging in stimulant use. And then, of course, it becomes very important for us to encourage mental health treatment for ADHD, depression, and substance use disorder. That's what you might do for the students. But the students are existing within a system. And that system involves campus police, it involves the prescribers, it involves the parents. And so looping them in to that conversation becomes important. People should know what it means to be in possession of a stimulant that was not prescribed to them. We also want to work with our prescribers, MDs, DOs, nurse practitioners, PAs, to make sure that they are checking prescription monitoring program and making sure that people are prescribing responsibly and ethically. And we also want to empower parents to not really turn a blind eye to this type of activity in favor of grades, which can be challenging because I think so many people are really focused on that. When it comes to providing support to queer individuals, there's some data that suggests that even just having a gay straight alliance can be in a particular school can have many, many positive effects from both a mental health standpoint, from a suicide reduction standpoint, but it can also reduce the risk of engaging in substance use of lots of different kinds, and including ADHD medication. And then, of course, targeting HIV risk behaviors, really encouraging people to know their status and that of partners, and doing a better job of like promoting both PrEP and PEP for people that identify as queer. So a couple final points, and then we do have some time for conversation. I think it's important to kind of acknowledge that psychostimulant use is widely varied based upon the multiple identities that people bring to the planet. So if we can keep in mind and hold in mind that there are lots of different types of ways that people experience psychostimulant use, we don't have to see people as a monolith. We can look at the human being in front of us and the humanity of the person. It really can be helpful in establishing connection with that individual, establishing connection with the members of that community, and then providing educational interventions and prevention that is really both culturally competent and steeped in cultural humility. We've spent a lot of time today talking about the historical relationship as well as current factors that members of vulnerable groups that they might experience and how that plays into the health disparities around the development of substance use disorders, as well as the increased likelihood of experiencing negative consequences from engaging in substance use. That knowledge can hopefully help us to enhance the quality of our prevention efforts. We want to tackle social and structural determinants of health as part of our overall prevention aspect, prevention work. Now, that can be particularly challenging when many of our organizations and some of our communities don't have access to lots of resources. It would be wonderful to be able to offer housing to everybody that came in who was unhoused. So, but at the same time, thinking about like, okay, well, who can I partner with? How can I build coalitions and relationships with other community resources and prevention network members to reduce some of those structural determinants of health that will then further reduce the likelihood of engaging in substance use. And then finally, I think it's really important to seek feedback from community about their needs and their perspective, and then involve members of the community in the creation of prevention efforts. So with that, I'll take questions and comments, and